Assalamu alaikum warahmatullahi wabarakatuh. We will start from where we left yesterday. So we had some questions of pain. So I think this question is also with reference to pain. So there is a 73-year-old woman with metastatic breast cancer. Okay. So as you know that what's my message for all of you is that you should practice MCQs in a way that you are having mind exercise with all the things which are related to that topic and related to that scenario. So you should be thinking about what are the concerns in a metastatic breast cancer. I will explain to you shortly. So one of them in one of the problem in the cancer is pain. Okay. So that's what you are seeing. You will be seeing in this scenario that there is severe pain in her back, upper arms and legs. Okay. She has been on increasing doses of modified release oral morphine and paracetamol. Then another point you can just think in your mind that actually the chronic pain therapy or say cancer pain, uh, the WHO step ladder is from starting from the simple analgesics and going to higher up. However, the WHO step ladder for acute pain is you start from the maximum and gradually you come down. Okay, so that is the difference between the pain management strategy in acute pain versus chronic pain, or you can say cancer pain. Okay, so this is another point. And then again, this next scenario is that while this provides some pain relief, she is troubled by drowsiness, pruritus, and constipation. Okay. So another point that what are the side effects of morphine? Okay. Respiratory depression, drowsiness, pruritus, constipation, like ileus. So these are the things which you should be thinking. Then at times she feels this is more distressing than her initial pain. So this is just giving a hint that there is a concept. When you read about opioids, you will come to know that there is another scenario, what is called as opioid-induced hyperalgesia. Opioid-induced hyperalgesia. Okay, so that's one of the reason for not using too much opioid because opioids are addictive. Opioids have a lot of side effects and this is one terminology which I said hyperalgesia means increased pain sensation. And actually, opioids are upgrading the receptors and they are causing more pain than the original one. That's what she's saying here. Additionally, she's on warfarin for atrial fibrillation. Okay. So, warfarin is, you can just think it about it that is it like anything related to metabolism of it? Anyways, let's see. Because this is just an open question. Add diclofenac, reduce the dose of morphine, add naloxone, opioid rotation, prescribe a laxative. So laxative is with reference to constipation. Opioid rotation is that if one opioid is not getting the result, maybe you can change it with some other opioid and maybe it can help. Naloxone is uh, opioid antagonist. So if you give naloxone, the effects will be reversed. So that's not a solution. So let's see whether it is diclofenac. Diclofenac, why will you not give? Just think about diclofenac. That because of warfarin, there is already a tendency to bleed. So diclofenac sodium NSAIDs, they have some effect on bleeding. So maybe this is one of the reason. So let's see, because opioid rotation, I don't think so it will solve solve the problem. Let's see what is the answer. The answer is reduce the dose of morphine. Okay, so this is what I was saying that opioid induced hyperalgesia. Pain is a common symptom among those suffering with malignant disease, and its management can be challenging. Etiology of pain is in cancer is multifactorial. Mass effect of tumor, effect of treatment like radiotherapy, chemotherapy, paraneoplastic syndromes, conditions associated with the disease process like osteoporosis, hypercalcemia, pre-existing pain from other chronic conditions, and combination of any of above. So these may be the reason of pain in cancer. And there is also an element of psychological because the patient is depressed. Patient have some element of development of neuropathic pain as well. Okay, opioids are very effective in management of cancer-related pain in general. To begin with, most patients are started on long-acting oral opioids to treat background pain, supplemented with additional doses to treat breakthrough pain. So you should be knowing what is breakthrough pain. Breakthrough pain is the one which is initiated in between, okay, because of some increased stimulus or something. So background is the one which is the baseline requirement, and breakthrough pain if in any additional pain is there. So oral morphine is suitable agent for most patients, but different people may display an unpredictably different benefit side effect profile with different opioids. Okay, so let's see. So you will find so many points about pain management in this slide, in this chart. So WHO analgesic ladder is a guide, but sometimes patient may need to start with strong opioids in the early stages of treatment. This is the an atypical point against the WHO step ladder. Adjuvant medications such as ketamine may be required. Anti-neuropathic agents such as antidepressants or anticonvulsants like pregabalin may be required. Okay? Steroids reduce edema and inflammation around tumor growth, hence reducing local mass effect. So, role of steroids. Bisphosphonates for bone pain from osteoporosis or metastasis. Antispasmodics or laxatives for the with reference to constipation. Okay, so these are the things which are additional point. With reference to cancer, I will say few words that whenever you heard about cancer, there is a mass effect and local spread. Okay, and then distant spread to, for example, liver, lungs, bone, bone. Okay, and it may be leading to the reason. One of the reason for pain is metastasis and even the bone pains. Okay, so just a second, please. Okay, so you should be knowing about these things. Then, like it also depends on the location of cancer, whether there is any lymphatics are involved, and there may be some edema. Okay, and then cancer is a pro-thrombotic condition. So the patient is at risk of DVT. Then the chemotherapy and radiotherapy has effects. Okay, so chemotherapy has multisystemic effects, effect on bone marrow, effect on liver, kidney, okay, lungs even. So chemotherapy agent. Radiotherapy also has bad effects, especially if the radiotherapy is with reference to airway. It will causes like distortion of airway, and if patient has received radiotherapy in the neck, you should expect distorted airway anatomy and maybe like a difficult airway. Okay. Similarly, as I told you, opioid addiction or opioid related problems, psychological problems. So there are so many things which are there in the cancer patient. So whenever you are treating such things, you should all be thinking about it. So these are general mechanisms. So and actually chemotherapy and radiotherapy is leading to decrease in the cancer uh, spread or cancer size, so it will reduce the pain. So this is also part of pain medication, pain therapy. Okay? So surgical treatment of gastrointestinal obstruction. So for example, if there is a cancer in the abdomen and there is intestines are involved, so maybe ileostomy or colostomy creation will reduce the pain. Okay, reduction, and this may be a part of palliative care. This is another thing. Reduction and treatment of pathological fractures. So this is another thing, something you should be. And CSF shunt procedures with reference to, for example, if the tumor, because there are so many things you can think about it. If abdomen or GIT is involved, you need to bypass. If there is a CSF like brain, for example, if brain tumor, so maybe it is leading to raised ICP. So maybe the CSF shunt procedure will help in decreasing the symptoms. So these are all part of pain therapy. So because why it is important, but because even in MCQ, they can uh, they can make a point with either of these things which we are discussing. So that's why if you don't understand each and every word related to this discussion and this explanation. you can have problem. So whenever you are reading any source of explanation for even MCQs, you should be explaining, getting the what is the role of spinal cord stimulation. So it is also acting like a gate control theory. Okay, acupuncture also like that. Reflexology, this is another like non pharmacological therapy. Also this brief like counseling, grief counseling, cognitive CBT, yesterday we discussed about it, relaxation techniques, pain management programs. So then another question which they can ask, especially if the people who are going for viva, or even if you are preparing for some exam, there is a concept of acute pain service. Okay, acute pain service. So this is another thing which is related to the pain management. There is one acute pain service, there is one chronic pain service, and then there is palliative care. So you must know that in some conditions there is no hope of survival of the patient. So the treatment which they are giving is only to reduce the symptoms and to have an easy death. So another point you should be thinking about any patient with cancer, what is the concept of end of life care? End of life care. So whatever topics I have told you, you should explore. Okay. End of life care, as I mentioned. End of life care means one of them is uh, DNR. So they can ask you, especially the people who are going for any international exam, there may be some MCQ or some point about this. Do not resuscitate. Okay. Then another concept of palliative care. Okay. Palliative care is like there is no chance of survival, and whatever care is being given to ease the symptoms and ease the journey, okay, towards death. So this is a concept of palliative care. Then another thing, as we discuss about chemotherapy, radiotherapy, the systemic effects of chemotherapy, and then psychological problem, opioid dependence, and opioid related problem. And in also in palliative care, they sometimes they are giving sympathetic blocks. Okay, so sympathetic blocks are also, you should be reading about them. Okay, so and then we also discuss about WHO step ladder. Okay, so these are the points you should be thinking, or you should be knowing about it. Any relief in the symptoms, like by laxative or antispasmodic. So these are the things we should be knowing. As also written here, spinal cord stimulation, yesterday we discussed about gate control theory. Okay, so spinal cord stimulation, acupuncture, TENS, and even when we rub, this is all gate control theory. When we stimulate, a beta fibers are stimulated and it will lead to relief in pain. So yesterday we discussed this topic. uh, okay, so in general, a low dose oral preparation is commenced. The dose is then increased by 30 to 50% gradually over interval of 2 to 3 days until adequate control of symptoms is achieved. If using morphine as an example, appropriate of breakthrough pain would be 1 by 6 of the total daily morphine requirement. This is some point. Uh, it is not uncommon to use parenteral routes to administer opioids. In palliative care settings, opioids are frequently administered subcutaneously by syringe delivery, syringe driver. Those on very a large oral morphine may benefit from a fentanyl patch. Do you know why fentanyl is being used in patch? Because it is highly lipid soluble. So it can penetrate through the skin or transdermal route. But morphine is least lipid soluble. So morphine cannot be used in subcutaneous route like this. Sorry, this transdermal route like this one. So these are another point which are in use. Okay, long-term opioid use is associated with significant unwanted effects. So this is a event for dependence, tolerance. Can anyone tell what is difference between dependence and tolerance? Yes, nobody wants to speak out. Actually, independence, like patient is unable to survive or unable to have like life routine without taking it. Like the patient will not be able to do anything. So that is dependence. And tolerance is that you need more dose for the same effect. So this is a little bit difference between tolerance and dependence. And then another thing, withdrawal symptom, which leading to hyperactivity. So that is a little difference between dependence. Dependence will lead to withdrawal symptoms. So it's like that. Okay. So another option side effects is drowsiness, constipation, nausea, vomiting, pruritus. Okay. So then in MCQ they can ask you a question that what is the treatment pruritus? Usually we give antihistamine, but for this one you need to give naloxone. Okay. Urinary retention and respiratory depression. Okay. It will relieve the respiratory depression, naloxone, also as well as it will cause help in pruritus. Yes, for symptomatic relief it will be, but the opioid pruritus will not fully recover without unless you give this naloxone. Okay. Sometimes patient may report a paradoxical worsening of pain. Okay. This phenomenon is known as opioid-induced hyperalgesia, as I was telling you. Okay. Unwanted side effects will usually settle as tolerance develops. So unwanted effects will settle as tolerance develops. However, at times they may be more distressing than pain itself, as in this scenario. Okay. If adverse effects of opioids cause the patient notable distress or discomfort, they warrant specific treatment. The reversal agent naloxone has extremely short plasma half-life. So if you are giving for even replacement, there is a medication what is called as naltrexone, okay, which is long acting and it is being used for opioid like withdrawal symptoms. Okay, so that's a different thing. Naloxone has a short, so it cannot be used in this scenario. Okay, while it's useful for acute opioid poisoning, it has no role in chronic setting. In the first instance, the dose of opioid should be reduced, but other adjuvants you have to replace by like paracetamol, ketamine, antipruritic drugs, laxatives, and other medication for symptomatic relief may be considered. As I told you, that the other symptoms which are giving, they will be relieved. Failing this, opioid rotation may be attempted. This is a method by which one opioid is substituted for an equipotent dose of another, like oxycodone for morphine, like that. So prescribing a laxative is not the best option here, as it only tackles constipation rather than treating the problem of unwanted effects as a whole. Okay. So laxative will not be. So you see, when we read the explanation, we read so many things. So laxative will only treat the only one thing. Opioid rotation will be the next step, not the first step. Okay. And diclofenac, as I told you, they have not explained, but it is related to bleeding. They have given the warfarin that's for this thing. And naloxone, as we discussed, it's not very effective. Okay. So the next question. A 35-year-old man has been admitted to ICU with a 55% total body surface area burn. Yesterday, we discussed in detail about some topics related to burn. You can listen to the recording. It's there in the system in the YouTube channel. He's intubated and has been resuscitated as per the Parkland formula. So it is 4 ml per kg per person burn. Okay. So now which of the following statement is correct? Should temperature spike above 38 degrees centigrade, take blood culture and start empirical antibiotic. This seems to be correct, but let's see. And but anyways, let's see. Enteral nutrition should be started as soon as possible. This is also seems to be correct. Steroids are indicated as there is greater than 40% burn. No, steroid will not help. Fluid resuscitation should be continued according to Parkland formula, even if polyuria develops. I think this is also wrong. If fluid management is optimal, generalized edema is unlikely to develop. Generalized edema can still occur because of leaky capillaries. So rather, this is one of the cause, one of the problems in burn, that the intravascular volume will become even more decreased because of sequestration and leaky capillaries. So let's see which is the answer. Uh, so enteral nutrient should be why just a second. Should temperature, why I was just rethinking that maybe this is not related to sepsis in early phase. Maybe this is the reason, because usually it will cause later on, not immediately, the sepsis. Let's see. Okay, but burn and this you have to give nutrition following a significant burn injury, because burn is a catabolic phase. Okay, so if you are not able to replace the nutrition, this will increase the morbidity. Okay, it will create more and more problem. So resultant increase in BMR. So it's a catabolic phase, as I replace you, as I mentioned you, proportional to the size of burn and is thought to peak at 7 to 8 days. Early enteral nutrition is essential and has been shown to improve survival. Good nutritional support minimize the protein breakdown and improve wound healing and reduces infective complications. A high protein and carbohydrate diet is required. A patient with severe burn reset their baseline temperature to 38.5 degrees centigrade. Okay, this is something new for me. I don't know about this thing. It is therefore important to prevent hypothermia by ensuring ambient room temperature is kept between 28 to 30 as well as the usual warming measures. So this is something I don't recall for a time. Patient with severe burns reset their baseline temperature to 38 degrees. I have no idea from how it happens. But that's what I know, that patient will be prone to hypothermia. But I don't know about this thing. This is something new for me. Anyways, um, there is no evidence of prophylactic antibiotic in patients with burn. Diagnosis of sepsis in those is difficult as the burn itself results in SIRS that mimics sepsis. It is important to be vigilant to the presence of infection, as this represents a significant source of morbidity and mortality in major burns. To reduce resistance, antibiotics should be started following positive cultures or when there is high index of clinical suspicion. Skin grafting and aseptic dressing changes and patient isolation are all measures that reduce the risk of infection. Parkland formula, first 24-hour follow is merely guide to fluid resuscitation. This is just an idea, and almost you have to see the dynamic parameters or different parameters to see the volume status. Okay, is merely and will almost always need to be adjusted. Too much fluid can be detrimental as too little. Okay, the complication of over resuscitation include abdominal compartment syndrome because it will cause edema and it will increase abdominal pressure. Okay, because it will cause more pressure in the compartment. The need for fasciotomies to prevent extreme necrosis and pulmonary edema. Okay, the resultant SIRS leads to increased capillary permeability. So even if fluid management is optimal, there will be a degree of edema. First of all, remember one thing. Though I told you that when I was reading the options, two options seems to be correct. One is nutrition and other is the temperature. Remember one thing, this question, this book is old, and this question, you see, the reference is also old. Into later on, I think they changed the criteria with reference to Q SOFA. So I doubt about this question. Okay. So that's why remember one thing, these are all practice questions. Don't make your 100% concepts with them. This is just a brain exercise. You just need to understand what is, because now read it again. This is one of the component of Q SOFA, temperature, if I'm not wrong. Okay. So let's see, I'm reconfirming. Q SOFA is quick SOFA. Q SOFA score sequential organ failure assessment. No, so I'm wrong. It is not in the Q SOFA. That's why they have put it. Just a second. Because okay, so I was wrong. I was wrong. It's not in the Q SOFA. But it is in SIRS. Just let reconfirm. SIRS score for sepsis. Yes. Okay. Yes, you see, that's I was thinking. This is what is SIRS criteria. Four SIRS criteria with tachycardia, tachypnea, fever or hypothermia, and leukocytosis, leukopenia. So that is what I was saying. So that is, you see, this is 2016. So this is something you should be thinking whenever you are choosing the option. So that's why maybe they will not give you such question now, or you should be thinking about it, because now the guidelines say about the sepsis management in a different way. That's why I was a little bit confused about this question. Okay. So, but generally, the things which we are saying, antibiotic resistance is important. blood culture based antibiotic is important. Okay. And if there is some, because this is in this they have not given full scenario, so if there are some other tachypnea, tachycardia, so things may be a little different. Okay. So you can say that these two things are options in this, even this question. But of course, the more whole of the scenario will be different if they add something else. Okay. So the messages for him is steroids are not indicated. Nutrition should be started early. This SIRS, as I told you, and fluid management is optimal. Even then, generalized edema can occur in burn. Okay. So, and any formula is not absolute, and even then you have to see the fluid responsiveness. Okay, how much is change in CVP, how much is in change in pulse pressure variation. Okay, which will be telling you with reference to cardiac output monitoring. Then another extra points, let me tell you that also fluid responsive is through the vena cava diameter seen with the echo. Okay, they put the echo probe in the epigastrium and they see the fluid responsiveness through the superior is this inferior vena cava dilatation. If it is not if it is fully dilated, it means the patient is full in fluid. So you don't need to give more fluid. Okay. So similarly, urine output, skin, like overall picture of dehydration and fluid responsiveness, you should be thinking. That was the point. Okay. The next question. A hypertensive 68-year-old man on amlodipine. So what is amlodipine? It's calcium channel blocker. And actually calcium channel blocker mainly three categories. One of them is which is mainly affecting the heart. That is verapamil. The other one which is periphery like amlodipine, nimodipine, nifedipine. And the third one is what we say in between, transgender. So it has effect on heart less than diltiazem, verapamil. That this medication is diltiazem. Okay, so diltiazem has less effect on heart than verapamil and less effect on periphery than nimodipine or amlodipine. So it has it's in between. Okay, so you should be knowing, and I don't remember the name of the calcium channels, but you should be knowing one is L type and one is something T type, or forgot. So in the heart, the name of calcium channels is different than in the periphery. You can just reconfirm about it. Okay, so this patient is 68-year-old on amlodipine and it is undergoing elective AAA, abdominal aortic aneurysm repair. At the end of the operation, the surgeon is prepared to release the infrarenal aortic cross clamp. So this is question on the maintenance of the hemodynamics when they open it, because when they open the clamp, the debris, the anaerobic metabolism products suddenly will go in the circulation. It will cause vasodilatation. Okay, and decrease in SVR, decrease in cardiac output, venous return will decrease, so patient can collapse. So this is the theory that whatever question answer, let's see what we is appropriate answer, but it will be revolving around when to open, when to like we have to give some vasopressor. Let's see. Starting an infusion of norepinephrine 0.5 microgram per kg per minute after cross clamp release. Okay. Starting an infusion of dobutamine. So norepinephrine, what is norepinephrine? Norepinephrine is having predominant alpha 1 effects and some beta effects. That's why there is no tachycardia. Otherwise, if you are giving phenylephrine, which is pure alpha agonist, will cause reflex tachycardia. Okay, so this is you should be knowing about norepinephrine. Dobutamine is beta 1, beta 2 receptor agonist. Okay, so that it's causing increased contractility. But remember one thing, that beta 2 receptors are there in the blood vessels providing supply to skeletal muscles. Okay, because sympathetic stimulation, whenever there is sympathetic stimulation, and for example, a dog is running behind us, so we have to run. So where we need more blood? If sympathetic stimulation occur and if it is causing alpha 1 agonist activity, for example, it is only causing vasoconstriction. But right now we need more blood in the skeletal muscle so that we run away from the dog. Okay, so that's why we need more blood supply to the skeletal muscles. So the skeletal muscles, Allah has given skeletal muscles beta 2 supply so that they will vasodilate and there will be more blood flow. Then we need to run, so we need more oxygen. So there is bronchodilation, which is beta 2 mediated. Okay, and then we will produce a lot of heat. So our erector pylori muscle will and then there is sweating. Okay, so that is all. If you understand how it goes. So dobutamine has beta 1 and beta 2 effects. So is it needed? Because right now the thing is with reference to vasoconstriction. So let's see. I think more norepinephrine is more appropriate answer. Let's see the other option. Rapid infusion of 500 ml of colloid during cross clamp release. Actually, it may be effective, but here I think more important thing is norepinephrine. Let's see. This is also a possible option. So these two are possible options. Tilting the table in reverse Trendelenburg. No. Reverse Trendelenburg will cause more pooling of blood in the periphery. So reverse Trendelenburg is not the solution. It will cause more pooling in the legs. Okay. So Trendelenburg is the opposite position. Yes, if they say that foot side raise, okay, maybe this is one of the option. Optimizing the intravascular volume during aortic cross clamping. Let's see, because there are three options which can be correct. Rapid infusion of 500 ml of colloid during cross clamp release. This is one option. Norepinephrine and optimizing the intravascular volume during the aortic cross clamping. Because let's see what is the answer. Optimizing the intravascular volume during aortic cross clamping, because this was a quite confusing statement. Not confusing statement. These all options are correct actually. We need to give albumin, we need to give norepinephrine, and optimizing the intravascular volume during the aortic cross clamp is one of the option. Because if sudden if we are not lagging behind this, let's see. Hypotension following the application of aortic cross clamp is a significant intraoperative event. The most effective intervention that can minimize this hemodynamic instability includes optimal volume resuscitation during the pre-release phase and gradual release of aortic cross clamping by the surgeon. This is one. Although they have a role, vasoconstriction and inotropes are not as effective if initiated following aortic. Maybe the answer was to before opening. Hypoperfusion to the lower limb lead to anaerobic metabolism, metabolic acidosis, and hyperkalemia. Okay, so this is just like a tourniquet. So this in turn reduces the sensitivity of adrenergic receptors in the affected area. If used, vasoconstrictor will increase SVR, causing vasoconstriction in the upper limbs, potentially diverting the blood away from the central compartment and thereby compromising cardiac output. This is something I did not appreciate, but this is a very important point and this is logical. Again, I will repeat. Although they have a role, vasoconstrictor and inotrope are not as effective initiated following aortic cross clamping. Hypoperfusion to the lower limb leads to anaerobic metabolism, metabolic acidosis, and hyperkalemia, like a tourniquet. This in turn reduces the sensitivity of adrenergic receptors in the affected area. Wherever there is acidosis, there is less effect of vasoconstrictor. So that's what they are saying, that they will preferentially affect more on the upper limb. So increase the SVR if it will increase, causing vasoconstriction in the upper limbs, potentially diverting the blood away from the central compartment and thereby compromising cardiac output. This is something this is new information. Administration of fluids is less effective in the post-release phase, and a 500 ml colloid bolus during the release of cross clamp is often insufficient resuscitation. That's the reason I think that 500 ml is not sufficient, maybe more than that. Tilting the table head up would only decrease the left ventricular preload and causing hypotension. Therefore, carefully optimizing the patient's intravascular status throughout the operation is the safest method to mitigate the predictable hypotension following aortic cross clamping. So I think this is something important. Aortic cross clamping, I don't have I have not done much of these cases, and actually because usually now they are doing a number of time endovascular. So in endovascular, things are a little different than the open. Anyways, so again, this is a point which is something new. You should be considering this, that vasoconstriction will predominantly it will cause vasoconstriction in the upper limbs and diverting the blood from the central compartment. Okay, next question. So dobutamine is not effective, norepinephrine, as we discussed, and Trendelenburg may help, and this is the correct option. This one is not sufficient. That's why they are not considering it. Okay. Now we have a 74-year-old with palpitations, heart rate of 156, atrial fibrillation. Okay. Which of the following would not warrant immediate uh, direct current cardioversion? Like they are saying that in all of the condition, they need to do the DC cardioversion except. Okay. So let's see. If the BP is so low, maybe it is needed. If GCS is going down, this is, let's see. Bibasal crepitation and tachypnea. Sweating with cold, clammy hand. This will be there. T wave inversion in lead AVR. Actually, T wave inversion in AVR is normal. So this will not, this is not, I think this, let's see the answer. Arrhythmias may occur preceding a myocardial infarction or may lead to ventricular fibrillation. Thus, it is necessary to identify them and treat them without a delay. As with any other medical emergency, there need to be A, B, C, D, E. Airway, breathing, circulation, disability, exposure. A 12-lead DC which warrant difference between broad complex and narrow complex. It is important to look for features suggesting clinical instability in view of the arrhythmia. Okay, so these are sign of pure perfusion. So, eh, shock, hypotension, pallor, cold, clammy extremities, sweating, confusion, or impaired consciousness. So actually, I will read the question again because maybe I have not read in nicely. Okay. So actually, in this one, there is this is because this is a normal phenomena. So they are asking that this patient has fast AFib. Okay. So which condition you will not do DC cardioversion? This is the question. So that's why this is the normal thing. Bibasal crepitation and tachypnea mean patient has some insufficiency. Sweating is also, GCS is also, and blood pressure is also. Do all these four things showing hemodynamic or respiratory insufficiency. Okay. So that is why this is the answer, because this is a normal phenomenon. Okay. So hypotension, pallor, cold, clammy extremities, sweating, these are all signs of instability. Syncope, transient unconsciousness due to compromised cerebral blood flow, myocardial ischemia with chest pain, ECG changing, heart failure, pulmonary edema or raised JVP, or with or without peripheral edema or enlarged liver. E-wave inversion in AVR is normal ECG morphology. Okay. Therefore, not an adverse feature necessitating urgent intervention. Just a quick revision about like what, like any unstable, like unstable SVT, unstable VT, not pulseless, unstable VT, it AFib or flutter. Okay, so and all, so we have to do the synchronize cardioversion, DC cardioversion, and we synchronize with what? R wave. Okay, and if it is coming on T, so it is R on T phenomena. So these are the points which should be knowing, and then you can have the information about how much joules are used gradually for different scenarios. Okay, usually it is, I think, 2 to 4 joules per kg, something like that, if I'm not wrong. but follow ACLS algorithm for it. Okay, a 3-year-old boy suffers from dry skin, scaly skin, oral thrush, dandruff, and dry hair, as well as poor vision in dark. So on examination, he has cirrhosis or better suppose I think it's vitamin A. Let's see. D or C? Vitamin A. Okay, with reference to actually D is with bones, C with also with skin. There is a disease what is called as scurvy, I think. Let's see. The patient present with clinical features suggesting vitamin A deficiency. Vitamin A is essential nutrient whose deficiency leads to eye and skin manifestation. Okay, it is found as retinol and beta carotene in the diet. Retinol comes from animal sources like liver, fish, eggs, whereas beta carotene is found in fruits and green vegetables. Peak incidence of vitamin A deficiency occurs in children aged 2 to 5 years due to poor nutrition. Skin effects are seen in repeated skin infection, acne, and dry skin. It can also lead to thrush and dry hair. Vitamin A deficiency leads to dry conjunctiva, like which is called as xerosis, and night blindness. Small raised gray plaques are found in the interpalpebral conjunctiva called bitter spots. Corneal ulceration and perforation may occur in extreme cases. Treatment is by administering retinol, palmitate intramuscular, or beta carotene orally. So this is just least likely to be asked in our exams actually, because usually they are not asking. But anyways, you should be knowing. And another word I will say: I have never seen a rabbit going to an eye specialist, because rabbit eats a lot of carrots, and carrots have very good amount of this vitamin A, which is good for these things. So rabbit will not develop vitamin A deficiency. Okay, so eat carrots. So you see the word which you should be knowing: this bitter spot in the conjunctiva, dry conjunctiva, which is xerosis. Okay, and overall, which is the retinol, which is beta carotene, and retinol, which is required for night vision. Okay, as soon as we enter in the dark area, after some time we start finding some vision. So that is the role of vitamin A. Usually, when we reach such place, we lose our vision. So I think I will stop here, and inshallah, we will continue from tomorrow. We have finished one paper actually. Okay, so we will start with the second paper. Actually, the concept behind this discussion is actually because I tell you something that, again, my point of view is the same, that if you clear your concepts, okay, the things will become much easier for you. But this point you should not forget, that MCQ reading alone is not the solution. Okay, MCQs reading alone without any understanding, and if you are only trying to cram the answers, this is not the solution. Rather, it will hurt you badly. So, whenever you are preparing for MCQs, please read the concept, read the whole, what our things are related to it. Just do the brain exercise, and whatever points are written, as whenever I'm uploading, I'm just writing also the topics which we discuss. Okay, so fetal circulation, coarctation of aorta, burns, trigeminal neuralgia. So I will write for each topic. I will each discussion I will write. Okay, so thank you all of you who bring out their time to attend. But remember one thing more: very few people are attending, and I am giving my personal time for you guys, and like, it's for your benefit. If you will listen, you can clarify some things, and when you read, it will be easy. But remember this thing, that please don't cram the answers. Rather, you should not read the questions again. You should just extract the points and note it down in your brain, or note it down. This also I give a suggestion again and again: start making audio notes. Okay, and audio notes that I read this question, it has this one, this one, this one, and on the basis of this point the answer was this one. and these are the things which I should know, that what is this, what is this, what is this. So you can make your audio notes, you can record, and you can save in your mobile. And when you are at a place, like you are at workplace, you cannot open the book and study, or you don't want to read, you can just play with the headphones, and you can just listen, and this will be your revision. Okay, so my suggestion to you, that use this way, it will really help you. Okay, so thank you, special thanks to the busy people like Hamza Noon. Okay, so the big people like Hamza Noon are giving time. This is something adorable. Okay, so thank you very much, all of you. Bye bye.